Don't worry, no one here has to say my last name. I'm gonna make sure I know how to work this. Okay, so I am hyper aware that I am one of the few that stands between you and finishing your day, so I will be brief. I'll start this conversation with a full disclaimer that I am not a clinician in any way, nor have I been clinically trained. I just have dedicated the majority of my career to my passion for public health. And so when I'm sharing with you today how the American Heart Association views the topic, I want you to know that basically as we're looking ahead, we're taking a look at there's a very large need to address public awareness and then build a plan moving forward, and that's what I want to talk to you about today. So I want to talk about who we are as an organization just very briefly. Our mission, we're getting ready to celebrate 100 years, and our mission is to build a world of longer, healthier lives. We want better quality of life. Obviously, if you look at the trajectory of who we are and some of the milestones, we began by a group of 6 cardiologists who were interested in helping people not die anymore from CVD and other vascular diseases. And then over time, we shifted our focus to prevention, and that's how we arrived where we are. And so I want to talk about the need and how we came about building a national action plan around PAD. We heard this earlier, but PAD afflicts 8 to 10 million people in the United States, majority of which we know are about 65 years or older. But the interesting thing that we've observed is that there are higher rates of peripheral artery disease in Black American men and women, and Hispanic men and women have similar disease rates as their non-Hispanic white counterparts, but they present clinical attention at later stages in the disease. And this is just a quick, brief overview of who we are seeing as most at risk, many of which you heard about earlier, but the one thing I wanted to double click on is that there are other factors that we recognize, usually socioeconomic in nature, like income level, education level, access to care, that can obviously impact those health outcomes. And then recently, the American Heart Association, not recently, 2012, released a statement where we essentially highlighted this call to action around Roman and peripheral artery disease. And the main thing that I wanted to point out here is that in the statement, we could talk about that the age-dependent prevalence of PAD in adult women is lower than for men. The burden of PAD seemed to be higher. And this matters because it's on track to triple in the next 30 years unless we do something about it. And that's where we have stepped in and are interested. And this is just a few stats that are our why, if you will. We're on track to see 19 million people with PAD by 2050. 16 million of those would be about 65 years or older. And some of the stats suggest that a third of those diagnosed with PAD will die within 5 years of their diagnosis. And then obviously the link to an MI or stroke. So, what are we going to do about it? Well, in about 2017, we pulled together peripheral artery disease task force, and they built this roundtable report. It's really interesting, and it kind of dives into some of the things, like there was focus groups and research and a lot of community surveys focused on a couple core groups to gather some more information about what direction we were going to go next. And a couple of things that we realized from those focus groups is the general lack of awareness around PAD, but then also a general lack of awareness of knowledge of PAD symptoms. So, and on the other side, the general public just not understanding or knowing their risk. A couple of key takeaways that I wanted to share about the messaging from the focus groups are just some of the interesting things that resonated. Leg attack resonated with focus group members. Connecting PAD with losing a leg provides a powerful message, as you can assume. A couple things that we were looking at, especially when we're translating materials, we're often very interested in providing our educational materials in a number of languages, and so we have to be cognizant of how some of our key messaging translates to different audiences. And one of the key takeaways that I was taking a look at, just can't keep up is confusing and also not translating well in Spanish. And then the term peripheral implies that PAD is not central to health. So these are all just some interesting key takeaways from the focus groups that we learned at the time. So we built an action plan. In 2021, we hosted a summit, and I wanted you to see who was there with us. So we rarely do anything alone. We had a lot of participating organizations who stood alongside us to sort of develop this national action plan moving forward, to the likes of diabetes, ACC, CDC, many of which you see listed here. A lot of thought leaders in the vascular space. And so it features 6 strategic action plan goals. We rarely do anything without a good structured goal line and framework. Here are a couple of them. I'm going to dive in just on a couple really quick that I think are relevant. The first one, obviously, with anything else that we do, is public awareness. A couple key points here is that we aim to establish a diverse national patient advisory group that will help us communicate to address public awareness gaps and how to best communicate them, sort of like I indicated earlier. Also, make sure that we were prioritizing the approach to reach the at-risk groups for the messaging, and then be thoughtful about securing funding to launch and sustain PAD consumer awareness initiatives. The second was professional education, and I'm going to show you some samples of what came out of this, which was pretty great, but just making sure that we were very focused on the development and dissemination of educational curriculum to multidisciplinary healthcare professionals, increase awareness, detection, and screening of patients that were at risk, and then provide practice support and improvement patient access to guideline-directed medical care. The third goal was detection and treatment. So we wanted to make sure we improved detection, make sure that we were developing approaches that were patient-centered. And then fourth was public health, as always. And then taking even further look at policies, urge expert organizations, governmental agencies, public organizations, and the media to highlight amputation, since we knew that resonated from the focus groups. And then research was the next. Rarely anything that we and many of our participating organizations do is not without evidence-based guidelines. And so we wanted to make sure that we maintain focus on basic and translational research, grow clinical research, and then make sure we're also advancing research in CLTI. And then advocacy. Obviously, I think we're going to hear a little bit more about that in just a moment, but making sure that we were thinking about our role in helping create things like a PAD advocacy toolkit, for example, or mobilize PAD advocates to influence policymakers in support of our advocacy agenda. So out of that came a number of tools and resources. One of them was some good old basic key messaging for public awareness, and there's an example here on the slide. Another is our toolkit for professionals, and this was a neat thing for me to sort of review because it has an array of things like podcasts. There's a video series, and then we also have, you can see at the bottom, our online learning series that involves, if you want to have, you can register for CMEs and things like that, continuing education. Another thing that came out of this was a focus on real stories. We heard about women not recognizing or speaking up for themselves, and so one of the things that came out of this was making sure that we had women's stories featured so women could see themselves in those stories. And then also another thing that came out of the action plan is a PAD patient education guide. And so this is a focus, a clinician's guide. It's tons of tools and resources in here. A couple of them look like how to talk to the patients about PAD in a way that will resonate based on some of our focus group, and how to build that dialogue. And then the other was the patient-centric resources. This is just an example. There are many, but it's a symptom checker. So something that sort of speaks their language, they can take with them, be cognizant of their own symptoms, bring it into their clinician. The idea is early detection. Another thing that existed, honestly, before the Action Network was built is a support network. And this was originally for CVD patients, anybody who had an event. And the idea was to bring patients together and to connect, and to, if you hadn't known anyone who had your condition, you might be able to connect with somebody across the world who had, and have that camaraderie. It's also for caregivers, but where this was elevated, obviously, was expanding that for PAD patients. So, bottom line, when we think about our community impact and trying to meet the needs of patients in the community where they are and bringing awareness to PAD, is that we spent a number of the last 5 years building out this plan and lots of evidence-based, science-based tools and resources, but if they're not being used, then what are they good for? Especially when you think about some of the brightest minds sitting around that table to develop some of the resources. And so these are some ways that we're hopeful that our community and surrounding communities can utilize the tools. And so we have our landing page for this is heart.org/PAD, and there are many ways in which, no matter what seat you sit in, you can engage in the conversation around awareness, advocacy, patient care, how you might approach as a clinician, and then also making sure that we're getting the tools and resources in the hands of as many people as possible, and then also making sure that the patients have access to those tools and what goes home with them. Many a times I meet with those who are survivors or have lived with it, and they say to me, I walked away really confused, or I didn't know, or I have so many questions. And so trying to pair and create more dialogue and get them tools and resources in their hands as well. And then generally speaking, awareness. And just making sure that in our role as the American Heart Associations with our supporting organizations, that we're doing everything we can to create that next level awareness around not only peripheral artery disease, but its connection to coronary artery disease and CVD, and what that means if you don't understand it, right? There's a whole different side if you don't understand the implications. And I think that's it. Thank you.
Thank you, Emily. That was awesome. Love working with American Heart and everything they stand for and what they do for our communities. Our last speaker of the day, very well known to the Tennessee, Hamilton County area. Bo Watson is a Tennessee state senator and has represented part of Hamilton County in the Tennessee General Assembly since 2004. Since 2017, Senator Watson has been serving as the chairman in the Senate Finance, Ways, and Means Committee. I think he's a strong advocate for our Tennessee dollars. I've watched him in action in chamber there. We've asked him to come and talk a little bit about legislative advancements, paving the way for enhanced patient care in the state of Tennessee.
Well, you probably can't think of anything worse than a political person being the last speaker of the day. And out of respect for you, I did not put together a PowerPoint. When they asked if I had any PowerPoint slides, I figured by this point in time, you were probably pretty much exhausted by seeing all the various PowerPoints. Thank you for allowing me to be here today. A little bit about myself. I'm a physical therapist by training. I work here in Chattanooga. In Tennessee, our legislative roles are not full-time jobs. People expect us to work them full-time, but they're not full-time jobs, and we often have other careers, and I'm a physical therapist by training, and In my spare time, I work at Park Ridge Medical Center, which is an HCA hospital here in downtown Chattanooga. I wanted to speak briefly with you about a few moments about what Tennessee is looking at in terms of paving the way for enhanced patient care. Some people refer to it as patient-centric policy making. A couple of things that we're challenged with, and you're probably experiencing that if you're in any of the healthcare sectors, are labor shortages across the spectrum, whether it's in nursing or in laboratory, medical technologists. I mean, the healthcare industry is experiencing incredible labor challenges, particularly at the hospital level, but that filters out into all different areas. And those kind of labor shortages affect access to care. People often think of access to care being a financial issue, but access to care can also be an issue of not enough people in the labor force to provide care. We've experienced this in family medicine for a number of years. The first action, really policy-wise, to look at trying to increase access to family care was in the 1960s, and we've continued on that path to try and create more primary care providers in order to get people into the door of health care, and then as specialization has increased, get people in the door and then allow the specialists to deal with a specific problem. So a couple of ways that we're trying to address our labor problem is one, through enhanced education programs. If you're from Chattanooga, you probably or may have seen in the paper last week that the University of Tennessee at Chattanooga has introduced an accelerated nursing program to try and matriculate students faster through their nursing program to get more nurses out into the marketplace, out into the field. We've had increased number of nursing programs open up. Of course, the problem with increasing the size of nursing programs is you then have to have an increased number of nursing instructors, and there's a shortage on the instructor side. So you're limited by the number of students you can have, by the number of nursing students, by the number of nursing teachers that are available. So we've been looking at a lot of different strategies policy-wise in Tennessee of how we can increase the pipeline both for nurses and other providers as well as physicians. We're looking at scope of practice laws as to the most popular one right now that's in debate in the legislature is nurse family practitioners and independent practice of nursing, and how much of that do we do in Tennessee and how much do we don't do in Tennessee. Currently, Tennessee medically is a pretty conservative state. We don't have independent practice. We have collaborative practice for our family nurse practitioners. There's a bill been introduced for probably the past 6, maybe 8 years that would increase the scope of practice for nurses and allow them to practice at the full capacity of their nursing licensure with independent and less collaborative practice. That will again be debated in session when we go back in January, but the message there is really we're looking at ways of how can we extend physician care. What are the physician extenders, be they family nurse practitioners, be they physician assistants? How can we extend care to create access points for patients to get into our healthcare system? And then we're looking at ways to try and get more and more students interested in healthcare or in science as a career path. In Tennessee, where only 40% of your students are reading at grade level, it makes you, by third grade, it makes you concerned about what your throughput is going to be in the future. And so focusing on K-12 education and literacy is critically important. It doesn't, a lot of times people sitting in a room like this don't think about the connections between elementary school and a physician or a nurse, but those students sitting in elementary school are the workforce of the future, and when the workforce of the future, only 40% are reading at grade level, it gives you pause and concern about what you're going to be doing in your higher education program and what your capacity is going to be to serve your population in the future. So Tennessee is taking a really close look at our educational programs. You'll see a lot of what used to be college level type of education being now pushed down into the high school level, where students can get credit for high school at the high school level for college classes, because we're trying to accelerate the rate at which students can move through higher education and move into, in many instances, professional education like medicine or nursing or physical therapy or others. We also have created, and a lot of states are looking at this, and I have if it's the fortune or the misfortune of I sit on a number of national task force, because every state, perhaps every country, but every state in the union is looking at this same problem and trying to deal with it with different strategies relative to how their state is composed. But one of the programs that we're now doing are combination programs. For example, we have a program, a relationship between Middle Tennessee State University and Meharry Medical College in Nashville, where certain students are selected based on the quality of the student in high school, and they get into a 3-in-3 program where they'll go to MTSU for 3 years, and then they are automatically admitted into the Meharry program, the medical school program. So it's a 6-year program rather than the traditional 8-year program that you might see. These are exceptional students. Not every student in high school is going to qualify, and we're just finishing through our first cohort has just finished their first year of medical school, so it's still a pilot project. But those are kind of, we're doing the same thing with nursing to where we're trying to increase the rate of throughput, not only the size of the pipeline, trying to get more people into the pipeline, but also trying to accelerate the people moving through the pipeline. So one of the biggest strategies that the state is looking for when it comes to enhanced patient care is making sure we have the capacity in our system to treat the people that are in our system. And currently, we don't have that. The second are some kind of operational strategies. I'm on a task force that's looking at the certificate of need laws that we have in Tennessee. That's been something we've been looking at for a number of years. Those of you who are really engaged in the legislative process will know that 3 years ago, we did a pretty significant and aggressive reform of our Certificate of Need program in Tennessee. We promised to come back in 3 years and revisit that. So this fall, we've begun meeting and talking about, are we going to tighten up or loosen up our Certificate of Need to make it more accessible to more competition in the healthcare space. So stay tuned for more conversation about Certificate of Need. For those of you who don't know or don't care what Certificate of Need is, there's a process by which if you're going to bring a new practice or new something new into the industry, into a community, under current law in Tennessee, in many instances, the state has to give you permission to do that, and there's a lot of regulatory control around that. From a free market perspective, a lot of folks have pushed to try and get out of Certificate of Need sort of regulations to allow the healthcare market to compete more aggressively with each other. So Certificate of Need is a big for companies, particularly healthcare companies. It is a big issue, and for individual practitioners as well. And then lastly, we are constantly looking at insurance and insurance reform. Most of healthcare, of course, we all know, is driven more by insurance than it is driven by the individual patient. We talk about, enhanced patient care, but at the end of the day, you have to be in a network, you have to negotiate with an insurance company. Oftentimes, it's not the patient that you're negotiating with. As a matter of fact, in most instances, it's not the patient that you're negotiating with, but it's their payer that you're negotiating with. We have tried to be fairly aggressive in our approach in working with the companies or the insurance companies that are licensed to health insurance in the state of Tennessee. We are careful. Tennessee is a very pro-business state, so we're careful. We try not to have too much government intervention telling insurance companies exactly what they should or should not cover. Although after a period of time, often with a collection of evidence and with a lot of testimony, we will end up making some things mandatory under any insurance company that comes into Tennessee. But we try to be more negotiable about it and less mandatory about it. But we continue to look at insurance reform. Obviously, for those that are in our Medicaid system, which in this state is a TennCare system, we are constantly looking and trying to learn from our providers about rates, and we realize, and anyone in this industry would know, that Medicaid rates are lower than Medicare rates, and Medicare rates are lower than commercial rates, and there's a delicate balance that you have to keep between all of those. We're constantly looking at our TennCare system and trying to make sure that it provides coverage that will keep practitioners in the Medicaid system, and at the same time, again, coming back to access, create access for the patients that are all across our state. Those are just three quick big hitters that I think it's important for you to keep your eye on and be engaged in. And let me say this as I finish up here. Most of the members, for those of you who don't know, the Tennessee General Assembly, there are 132 members, 33 in the Senate and 99 in the House. Those members are responsible for all the rules and regulations that govern all of medicine, both from a nursing perspective to a physical therapist perspective to a physician's perspective. While you have a board of medical examiners, or you have a nursing board, or you have a board of physical therapy, ultimately any rules, any laws are dictated by the General Assembly or the House and Senate of the legislature. It is critically important that people in the various professions be engaged in their profession. The American Heart Association spoke to advocacy. Advocacy goes beyond just, a particular disease process. Advocacy goes to protecting the integrity of your profession, enhancing the integrity of your profession. Most of that is through regulatory control, and most of that, if not all of that regulatory control, does not come from the federal government. It comes from the state government. You are licensed by the state of Tennessee. One of the big challenges that we're seeing is the advent of telehealth, and how does that work, or telemedicine? How does that work? How do you license a physician in Oregon that's providing telehealth in Tennessee? What do those licensing laws need to look like in the future? I carried the legislation. You now have physician compacts. I was the member who carried that legislation for you. I've carried every piece of compact legislation, from nursing compacts to physical therapy compacts to physician compacts. That's one way that states are dealing with this interrelationship that now exists because technology has made things and made people so accessible. And since the pandemic, people have gotten very comfortable with their telemedicine consult with their physician or their nurse practitioner. So I can't stress to you enough how important it is that you be engaged in the legislative process. As a fellow clinician, clinicians often say, I don't like politics. I just like to remind people a saying in the political world, particularly clinicians. If you're not at the table, they're probably having you for dinner, right? And so I would encourage you, if you're not engaged, to be engaged and help your legislature make good decisions about healthcare in Tennessee. Thank you very much for your time and attention. I appreciate it.
Thank you, Senator Watson. Just so that you know, he ended our program 1 minute early. So thank you very much, sir.
Thank you.
Absolutely.
Yeah.
Again, to everybody who has spent the entire day here with the FACES program, it's been, I think, another very successful year. We've had a great amount of different topics that we've gone through. You guys are troopers in the afternoon for just kind of sticking through things. But I do want to announce two things. One is a save the date for November 7th and 8th next year. It is going to be a combined ultrasound course the first day, and then a course very similar to this on the second. And then the winner for the VIC raffle was Alex Mullen. Alex Mullen still here? There you go. You won. You won. Congratulations. So, oh, is there more? All right. And, hey, when was this one? The other winner. What was this one for? Oh, for the alchemy basket was Maria Hill. There you go. Just in closing, very honored to be involved with this. We first started this off 6 years ago, thinking this would just be more of a small gathering. It's blown up into 200 people that signed up. Today we closed the spaces for this conference. And so I want to thank you all for participating. Questions were great. I think the speakers were awesome. And I thank you and look forward to seeing you all again next year. Thank you. We have a final question. Okay, yes. Okay, that's the last thing. The most important question. You reminded me, or I would have been in big trouble. So as you walk out, there is a small piece of paper on the checkout desk that will have the website that you go to get your CME. You have 30 days to get onto the website, answer the 10 questions, and give feedback for the conference, and then you can gather your CMEs. So as you're walking out, it is right on the table, and there'll be somebody handing that out to you. Great question. Thank you so much.